Ladies and gentlemen, it is such a pleasure to be with you today to be talking about a subject that is one of these things that we talk about all the time, but I think often rarely do well all the time, or we should be doing better. And I think we need to do what we say we're already doing. If you want to talk about a theme for this manuscript and this initial interim analysis, it would be that. It is to look at an interim analysis of a multi-center randomized control trial looking at a unique new novel micro water jet debridement tool compared to good quality standard of care debridement. And I want to acknowledge before we even get started, I'm David Armstrong. I'm a professor of surgery at the Keck School of Medicine of University of Southern California in Los Angeles, where it's always sunny, even when it's not sunny. It's sunny here. I want to acknowledge Dr. Carter, Marissa J. Carter of Strategic Solutions in Cody, Wyoming. And of course, Charles Zellen at Foot and Ankle Specialists of the Mid-Atlantic and Perry/MRI, who are my co-authors on this interim analysis. So let's get going looking at these very interesting interim analyses. And I hope I didn't bury the lead there. I don't need to tell this group that diabetic foot complications are common. They're costly. And they are complicated. We know now that someone with diabetes will develop a diabetic foot ulcer every second around the world. This is getting more common, not less common. Half of those will get infected. 20% of those infections will lead to hospitalization, which is why there's an amputation now around the world every 20 seconds. We have known for the longest time that in terms of good quality wound attention, that it is not what one puts on a wound necessarily that is primary to heal the wound. It's what one takes off. Good quality offloading of pressure and good quality debridement are really, really important. Recently, we have become aware of a unique water jet device, if you will, that may really very, very precisely surgically clean these acute and chronic wounds in a manner that might be even more tissue preserving compared to a good quality sharp debridement. And we wanted to put this initially to a test. And what you're going to be seeing now is the planned interim analysis of this, looking at non-healing diabetic foot wounds, which have a very, very high risk, as you heard, for complexity and hospital admission. The objectives of this, as we said, were to look at the healing rates and percent wound area reduction, or PWAR, as it were, in wounds debrided weekly over a 16-week period with this micro water jet device and good quality standard of care compared to just standard sharp debridement and the same good quality standard of care and debridement. We enrolled the first 50 patients of a planned, and this was a planned interim analysis. We plan to enroll at least 120 patients in the final power analysis. As you see there on the clinical registration number, these wounds were non-healing for at least a month with good quality or adequate blood flow and runoff, and were void of any clinical diagnosis of infection or osteomyelitis. After a 2-week screening period, eligible people were randomized, and there were 25 folks randomized into each arm for this interim analysis to get either good quality standard of care or that microjet debridement, as we mentioned. Both groups followed again for 16 weeks, undergoing a 2-week durable wound healing follow-up, which is now standard in many studies that we are conducting to ensure that we have good consensus on a definition of healing. And the primary endpoint here, as you see, is complete wound closure at 16 weeks. Secondary endpoints, interestingly, were not just percent wound area reduction, but also proportion of wounds with at least one infection. So the goal here maybe is in cleaning these wounds up, maybe we may see a delta comparing one to the other, or the null hypothesis would be that we'd see no difference between these, even at an interim analysis. And the results. Here we are, four bullet points. 72% of the micro water jet patients, the active group, healed, compared with 40% treated with standard sharp debridement. This was already unexpectedly significant at 16 weeks. In addition, the percentage wound area reduction was just under 87% in the active group, compared to 35% in the good quality standard of care group. The safety analysis also interestingly showed 1 AE and SAE in the active group compared to 9 AEs and 4 SAEs in the standard of care group. These were majority infectious in nature in the non-water jet group in the control group. The proportion of patients having at least one infection, as you see here, was essentially 6 to 1 in the control versus the active group, respectively. And if we look here, this is just for your right brain. I've already talked to your left brain with those data. What we see here is just looking at that percentage wound area reduction and the separation at a couple of weeks in these patients. One arm, the green arm, getting good quality sharp wound debridement with a scalpel. The other arm getting the active microjet debridement on a weekly basis as well. And we'll show a couple of case examples. We see case example number 1 in a patient with a dorsal foot wound. As you see here, the baseline wound, and then after it was debrided at 3 weeks, we see already a 60% trajectory toward healing, highly likely to heal at 16 weeks, and it certainly did even faster, this only at week 5. Good quality wound closure. And you see something else here. Now this is a plantar lateral wound after a couple of digits amputated in this patient with the past medical history of those in diabetic foot remission before developing this plantar lateral forefoot wound. And what you see here is that baseline wound. You see a significant reduction at study visit 4, already 50% improved in terms of percent wound area reduction, and then full closure at study visit 9 in this population. So, ladies and gentlemen, in conclusion, as we mentioned, diabetic foot wounds are common, they're complicated, they're costly, and they're getting more so for all of those things in this patient population. We need to look after these patients in a consistent manner. We mentioned it's not what you put on these wounds that heals them, although we like to use advanced wound therapies, but it's really what you take off. And good quality offloading, good quality debridement are sine qua non. Interrogating this area even better than we have been in the past is really, really important. The early data here suggests a potential delta favoring this micro water jet technology. In this planned interim analysis, we want further evaluation on our final analysis to either confirm or refute these initial interesting and promising findings. And then if we're really to have a kind of a key take-home message, I just think that if it's not all hands on deck, it's all feet on deck here as we approach this post-pandemic period and looking after these patients. Again, not what you put on, but what you take off. And if we can be taking things off in a more effective manner, then hopefully we can reduce the risk for infection, hospitalization, amputation, and keep a few more legs on a few more bodies and help our patients move through the world a little bit better, because I think that's what we all deserve, no matter what our health, no matter what our age. Mr. Chair, ladies and gentlemen, thank you very much.